Not a big portion.
Good morning, everyone, and welcome to OnLogic. It is wonderful to see so many of you joining us this morning for such a critically important conversation. By way of introduction, my name is Mike Kleiner. I joined the company OnLogic over 11 years ago and work in the product engineering team. And I also act as the OnLogic contact to the Vermont Healthcare 911 team. We're all painfully aware that healthcare costs in Vermont have spiraled over the last few years. This affects every single person and business in our state, whether directly through soaring premiums or indirectly, for example, through rising property taxes. It has brought us to a situation that is simply not sustainable. But as the event flyer reminds us, as well as the bold letters here on the screen, change is possible. Thanks to the incredible work performed by the Vermont Healthcare 911 team, we're aware of the root causes of the crisis, and the focus is now on making the right changes to bring things back to a healthy, sustainable state. OnLogic has proudly supported this vital initiative from the very beginning, back when it was just an idea. Today, we're excited to learn how university hospitals in Cleveland managed to do exactly that, reducing costs and patient wait times, improving quality outcomes, and empowering their staff to truly transform their healthcare system. I want to extend a huge thank you to Lisa Ventris for incredible leadership as champion of this initiative, and to the entire Vermont Healthcare 911 team. I also want to give a warm Vermont welcome and a huge thank you to our special guests who are innovators behind the success in Cleveland for making the trip out here to share their invaluable insights with us. I'm very much looking forward to the discussion, and once again, welcome to OnLogic, and let's get started. Thank you.
Well, Mike, thanks so much for your hospitality here. We're grateful to you and your colleagues, Lisa and Roland, who couldn't be with us today, but who've been very active in our VHC911 coalition. I'm Jim Douglas, and I have the honor of co-chairing our Leadership Advisory Council with Lisa Ventris, from whom you'll hear in just a few minutes. We're delighted to see such a wide, diverse group of Vermonters who care deeply about the cost of healthcare coming together today to help us focus on this important issue. A lot of people have asked me over the last year and a half, well, how'd you get involved in this group? I mean, weren't you comfortably retired down there, teaching an occasional course at the college and watching the sunset? And I said, well, yes, but I understand the criticality of the topic that we're covering today and how it fits into the broader issue of affordability in Vermont. This is, as many of you know, not a cheap place to live. Our housing costs are high and not always accessible. Our higher education institutions are very expensive compared to others around the country. We have one of the highest relative tax burdens in America, and our healthcare costs are disproportionately high. And we may wonder why it's hard to attract and retain people, why our population is stagnant and aging. Well, it's because it's expensive to live here. And there are multiple reasons, but we're focused today and through our coalition on the high cost of healthcare, and I think it's critical that we address it as we're doing through our coalition and a meeting like we're having today. I only needed to look at one chart, one graph that we presented a year and a half ago. From 2018 to 2025, health insurance premiums nationwide rose by about 12%. In Vermont, they rose by 92%. That's all you need to know. That's why it's unaffordable in healthcare in Vermont, and why it's so important that we do something to attack it. Unfortunately, we have great partners in that effort. We've got new leadership at the University of Vermont Health Network, Dr. Leffler, who is focused on this, who understands the importance of it, who's already met with our visitors from Ohio, and is dedicated to making a real difference there. We have a new CEO at Blue Cross, Beth Roberts, who's with us this morning. She understands the importance of reversing that trend We like to be number one in Vermont in some things, but not in health insurance premiums. And she and her team are going to do what they can to bring down those costs too. We've got a couple of members of the Green Mountain Care Board here today, Sarah Teachout and Dr. Merman, and we're delighted that you would take time out to be with us along with some of your staff. We've got some legislators here, some who aspire to be, and I hope that during the course of the morning you'll have a chance to meet them and to talk with them. We don't lobby, we don't get involved in individual legislation in Montpelier, but we're grateful for the work that the legislature did, especially last year, in making some real strides in the framework for healthcare reform and cost containment. So I'm really thrilled to be a part of this coalition. I hope you'll go on our website, VHC911.org. You can see our annual report, some of the information that we posted, our periodic newsletters. You can sign up to get our e-newsletters, and I think you might find that interesting. There's a video of an earlier webinar we had. This event is going to be posted on our website too. So a lot of important information there that I think you'll find really interesting as we move this agenda forward. So thank you for coming out this morning. Thanks for taking the time. You're all busy folks. You could be somewhere else, but you're here. And I'm very grateful to all of you, to the members of our board at VHC911, members of the Leadership Advisory Council, and to each and every one of you for being a part of this effort today. Now let me introduce Lisa Members, my co-chair of the Advisory Council and a great friend of many, many years and a wonderful partner in our efforts to improve healthcare in Vermont. Lisa.
Thanks, Governor. Thank you, Governor. Good morning, everyone. And thank you, Michael, for the hospitality today and the introduction, though I can't accept the praise for all of this. There's a board who in the audience is on the board for Vermont Healthcare 911, who is a member of the coalition of VHC 911. So many hands make light work, right? So it's game day. We've been planning this for months, and so we're so happy to see the turnout today. It's a great sign of the interest and the commitment that we all share to find solutions to Vermont's healthcare challenges. As the governor alluded, VHC 911 is united in its mission to find solutions to the high cost of healthcare in Vermont. We are consumers of healthcare, we are providers of healthcare, we are former leaders of healthcare institutions and programs. We represent educational systems and municipal governments whose budgets have been repeatedly voted down due to the high cost of healthcare that those budgets have had to absorb. We are business leaders whose economic growth and vitality has been constrained due to the lack of affordability in our healthcare system. We have served in state governments in elective and combative. Is that a Freudian slip? And appointed offices. And our political stripes range from left to right. And there's lots of fun stories to talk about how Chris Pearson and Governor Douglas came to work together on this issue. But together we represent almost 200,000 Vermonters, which is, as you know, almost a third of the population of the Green Mountain State. Since our official launch in January of 25, we've dedicated ourselves to educating the public and including Vermont's hospitals and healthcare system leaders by using comparative, data-driven examples that identify and break down the root causes of Vermont's healthcare affordability crisis. Again, the governor alluded to our website, which contains the archives for all of the work that we have produced during this time. 24 of our newsletters, which are in themselves wonderful lessons in healthcare economics and public policy around healthcare. 18 months later, we're starting to see a shift in the wind due to the leadership of Vermont's legislature and the passage of several important bills during the biennium, the strengthened authority of the Green Mountain Care Board, the critical and necessary leadership changes and culture shifts within Vermont hospital and payer communities, and the sustained efforts of our coalition to call for change that we know is going to be painful. As a result of these efforts, we see that our conversations no longer focus on why must we change, but how can we change, and who will lead those efforts? Opportunities are being created, and that brings us to today. So this gathering is a continuation of our work and reflects our cautious optimism, as you see in the program title entitled Change is Possible, Embracing System Change in Vermont Hospitals. This panel will run for 45 minutes, followed by a Q&A session. Please hold your questions until that time. Our session today is being taped by CCTV, and that will be up on our website later. Thank you, Steve, for your help. Now, let me move to our introductions. This is such an amazing panel, and we had great fun during dinner last night sharing healthcare stories, which we can't repeat here for privacy purposes. Nevertheless, we are so delighted to be hosting this esteemed panel. Dr. Craig Jones serves on the VHC911 Board of Directors and was previously the Executive Director of Vermont Blueprint for Health, Vermont's multi-payer healthcare transformation, focused on advanced community-oriented primary care. He is currently working with Vermont Agency of Human Services, supporting Vermont's healthcare transformation initiatives, including working with hospitals on regional transformation. Dr. Jones has published in a number of journals, served on committees with the National Academy of Medicine, and on the faculty of the Keck School of Medicine at the University of Southern California. Dr. Peter Pronovost, Chief Quality and Clinical Transformation Officer at University Hospitals in Cleveland, is a world-renowned patient safety champion. His work has earned him a MacArthur Genius Grant and a spot on Time Magazine's 100 Most Influential People in the World. At UH, Dr. Pronovost developed a management system to make defects in value visible and deployed a management and accountability system to eliminate those defects. This system reduced the annual cost of care for Medicare patients by 30% over 3 years, while improving quality. In 2022, Dr. Provost led the efforts that culminated in UH winning American Hospital Association's Quest for Quality Prize, the industry's most prestigious honor, recognizing its member organizations for their commitment to quality. Dr. Patrick Reynolds is Chief Medical Officer for the Vail Healthcare Transformation Institute and co-principal investigator at a John Templeton Foundation grant focused on studying and disseminating frameworks for transformational leadership in healthcare. Previously, Dr. Reynolds served as Chief Medical Officer at Population Health, during which time UH ranked among the most successful accountable care organizations in the nation, generating nearly $200 million in shared savings. Ms. Claudia Douglas is a managing director at Manat Health. She has spent her career transforming healthcare provider organizations toward profitable growth as a strategy and operations executive and consultant for over 30 years. She specializes in developing and leading complex strategic initiatives across multiple business units, primarily in the areas of strategic growth, leadership and governance operating model and culture, operational transformation and performance improvement, digital transformation and virtual and hybrid care, population health, and consumer and teammate experience. Ms. Douglas has worked alongside Drs. Pronovost and Reynolds at the UH system as they lead the transformation in their healthcare system, which includes their medical centers and health networks. So, with those introductions, let's welcome our guests. And I invite Craig Jones to take the mic.
Lisa, thank you. Can everybody in the back hear okay? All right, great. First of all, I want to thank everybody for coming today. It's really incredible that so many people made it, take your time out of your day. Everybody's busy. But this is a special opportunity. We're at an inflection point, as you've heard described, in the state. And we have a real opportunity here. And so we wanted to bring special guests here who can talk about how they engineered the change that they engineered. My job is to give a little bit of context. I'm going to make it brief because we want to get to the real showstoppers. This is the chart I believe Governor Douglas was referring to that captured him, so it's probably the best chart that we ever put out. We did a lot of data work, but it makes the point that Governor Douglas made, and it makes another point that I want to start the conversation with. You can see the inflection point. We changed. The rest of the country didn't change the same way. New Hampshire on our border, taking care of a lot of Vermonters, didn't change the same way. Maine didn't change the same way. And yet, the narrative 18 months ago in the state of Vermont was that the reason for our high premium costs was demographics. We're old, we're aging. It was, we are expensive because we're small. We don't have economies, scalable economies. It was Medicare doesn't pay our hospitals fairly, they underpay our hospitals. There was a whole litany of reasons, and we just kind of accepted it all. And that's really what brought 911 together, was say, this is not explained by those factors, we don't think. Let's dig into the data, let's start looking at national data and see what the reasons are. And that's what really brought the coalition together. Well, you can go to the next slide. When we started looking at the data, go ahead, Claudia, punch it down. We put out a lot of different things. I just pulled one slide. I don't want to go through a bunch of information for you, but just wanted to highlight the point. This particular chart shows the ratio of salaries at our hospitals that were going into general services, what it takes to operate a hospital, versus what was going into direct clinical care. This is what it looked like in 2023. Whether you used American Hospital Discharge Data, National NASHB Hospital Cost Tool, no matter how you looked at it, this was the pattern. We can quibble about the numbers, this was the pattern. And what was revealed is that our largest hospital and its network had very high operating costs, and a lot of it was going into management, administration, non-clinical services. And you can look at productivity, and I don't have to highlight that for you because the Green Mountain Care Board's liaison team that worked with UVM Health Network has put out their findings as they dug into it. And it all pretty much aligned with this type of pattern. But there's also differences here. What we see with the Health Network, Academic Medical Center, and some of our smaller city rural hospitals, which are really important anchors here in Vermont, isn't the same as necessarily with the critical access hospitals, and we have differences. And those are critical in thinking about as we talk about hospital transformation and regionalization of services, and we can get into that later. There's also one other slide I just wanted to highlight for you. What was behind this in addition to high costs? What was really driving the commercial rates? And we looked at it a lot of ways. So this is simply a chart, distribution chart, 2023 data, so it's not current. But at the time, this is how we looked when we looked at our hospitals. Are they making money or losing money on Medicare reimbursement, which is an important theme. And you can see our UVMMC, our largest hospital, over to the right side of this distribution chart. They were losing in that year around $900 million. That's what they reported on the Medicare cost report for that particular year. And then you can see a series of other hospitals along the distribution. The majority of them, not a large majority, but a majority, were making money on Medicare reimbursement at that time. We were clearly doing something different. And it was reflected in what we reported, what our hospitals reported as a loss. The chart I didn't bring is the flip of this, commercial profits in the same year. And on that one, UVMMC is in the top corner. They were number 6 in the United States on commercial profits when you looked at the amount they were making per discharge, all normalized and adjusted. That was the story at the time. As Blue Cross reserves were draining, and as we were entering into an incredible cost crisis. And that's really what drove the 911 work to dig in and produce the data that we have. The good news is, 18 months later, the discussion is entirely different. And we go to the next slide. We've gone from a place of looking at problems and reasons to an opportunity, the purpose of today's discussion. No longer are the same narratives holding, that it's nothing we can do about it, it's our demographics, we're aging, we're old, we're different than everybody else in the country. That's not holding anymore. The legislature, thank you, has passed guiding legislation that's really important. Some of it got signed. We have started initiatives in the state with AHS, including a large array of transformation initiatives that are underway, and I can't say enough how energetically the hospital leadership has engaged with the agency human services team in working on hospital optimization, improving efficiencies, regionalization. Many of you are here today that work on those things. Thank you, by the way, I really appreciate it. That work is energetic. That is a constructive upward force in terms of trying to build better access, better quality. And it's driven by the guiding legislation that was passed in particularly last year, but the last two. On the other side, we have a Green Mountain Care Board and thank you folks for being here, that has changed their approach in the last 2 years and has taken a targeted, focused approach at driving down costs, pushing hard a lever on hospital budgets. It's a blunt instrument, but it was something that had to happen in order to stop what was going on in terms of an uncontrollable fashion. And that paints the opportunity. The market forces aren't even up here. The people that won't buy insurance, how businesses will do, that's not even up here. But these are tangible things going on in the state which are under the control and the influence of you folks who are sitting in this room. We have this balance of pressures, the regulatory pressures, the transformation pressures that are acting right now, and we're at the beginning of it. And so the question is, will we do this right? Will we execute on the opportunities that are here? The many opportunities under transformation are big. These are not small projects, and the Rural Health Transformation Fund is intended to support them in various ways. Will we get it right? Will hospitals be able to respond and work on this as they're under the budget pressures that the Green Mountain Care Board is putting on them simultaneously? Those are difficult conversations. Leadership. That's really what this is about this morning. You can go to the next slide. And that's why we brought the team here to talk to everybody. They've undergone many of these same pressures in a large hospital health system, and they've engineered the balance that we hope we can strike here. So with that, I really want to turn it over to our guest, Dr. Pronovost. This is a summary of some of the work that they've done. It's a really unique leadership style, which has led to the awards and the recognition that they've achieved. But now's a chance for us to really dig in, and I encourage you during the panel, question them hard on the difficult things. Like, I heard you say Medicare money. How much commercial impact did they have? Let's ask them about those things. So while they're here, I want to turn it over. welcome Dr. Pronovost, and thank you for being here.
Thank you. So thank you all for joining. It's been great to make friends, and you have just an amazing plan. But before I tell you about our management system and accountability and organizational transformation, I want to tell you about a little girl named Josie King. Josie died from preventable harm in a hospital. Her mother, Sorrel, had every reason to turn towards anger, to hate us. Instead, she turned toward purpose. She challenged us with a simple question: what are you going to do to ensure that this will never happen to another family? That question has followed me, perhaps I'd say haunted me, for more than 2 decades. It followed me as a physician in the care I deliver. It's followed me as a patient safety research and policy person in how we design systems. And it follows me today as a healthcare leader. Because when you strip away all the complexity in healthcare, every metric, every dashboard, every strategic plan eventually leads back to a human being. A patient, a family, a caregiver, someone's Josie. And that realization led me to the very simple conclusion that the biggest challenge we face in healthcare is not reimbursement, it's not cost, it's not workforce shortages. It is simply our greatest challenge is that we have forgotten how to solve complex problems together. And there's a lot of them. And the simple reason is we've forgotten love. And that word may sound jarring, but when I use the word love, I'm not talking about sentimentality. I mean treating every person as worthy of respect and capable of growth, contribution, and excellence. Love says you matter. Accountability says because you matter, excellence matters too. Love without accountability is just sentiment. It goes nowhere. Accountability without love just drives fear and learning stops. We need both. The opposite of love, though, is not hate. The opposite of love is separation. And separation is at the heart of nearly every challenge that we face and why we struggle. When clinicians feel separated from their purpose, when staff feel separated from leadership, when departments feel separated from one another, when patients feel separated from caregivers, when the multiple agencies working on this feel separated from each other and the health systems. You see, when that happens, fear rises, learning slows, and improvement stalls. But when people feel connected, something extraordinary, truly extraordinary happens. They learn, they innovate, they solve problems, and they become capable of things they once thought impossible. And that is exactly what happened when we worked to reduce central line infections that Mark talked about. The checklist mattered. The science mattered. But the real breakthrough of what happened was people stopped believing that harm was inevitable and started believing that harm could be prevented. And they started believing that they were powerful to do something about it. You see, belief changed behavior, behavior changed the outcomes, and outcomes changed lives. That lesson was profound for me because we saw people rise to the level of what we believe about them. When we treat people as worthy and capable, they become worthy and capable in ways that they often never thought possible. That insight led to the foundation of our model of transformation that we call living and leading with love. It has three really simple pieces: believe, belong, and build. Believe that every person is worthy and capable. Belong to a community where every voice matters. Build discipline, management, and accountability systems that convert purpose into performance. Several years ago, university hospitals faced many of the same challenges that you faced. In 2022, we lost $222 million in operating dollars. We had mediocre quality at best. Our turnover was high, our engagement was poor, and we had to do something different. But you see, the issue wasn't a lack of talent. The issue was that we were not fully unleashing the talent that we had, and we had a lot of it. So we committed to believe, belong, build. We connected people to their purpose, everyone at the frontline staff, 35,000 people. We created structures for learning. We built management and shared accountability systems and transparently looked at performance. We moved from fear to learning, from hierarchy to partnership, from compliance to commitment. And the results have been nothing short of remarkable. Operating performance turned around so that this year we now made $55 million from losing 200. We took $600 million out of our operating costs. It wasn't easy We can talk about later all the things we had to do, but there was waste all over the place, and there's still a ton of waste. Length of stay declined from about 1.67 in our main academic center to now 1.36. That allowed us to increase our admissions and serve our community by about 15% more admissions every year. Our community hospitals now, as all 15 of them, went from an O to E to about 1.4 to 0.98 across all 15 hospitals. Just remarkable performance. We reduced surgical mortality by 70%, surgical complications by 65%. Our net promoter score is 83. It's gone up like off the charts. Our patient experience, where we went from one hospital was over the 50th percentile to now, on average, all of our hospitals are at the 85th percentile. Our turnover went from 22% amongst nurses to 12%. Our engagement score went from average to the first percentile in the country. And I can go on. There's like 400 measures. Because when you get this right, it's not one thing that improves. It's everything that improves. Because once you learn how to solve problems, or you get this culture right, it's just a virtuous machine of getting better in ways we never dreamed possible. But the numbers don't tell the whole story. The people tell the story. And I want to share two stories that just highlight the importance of this, especially the belief part. When we started this, we made a decision that the lowest goal we would ever set for our performance measures was the 50th percentile. There's a benchmark. We believe our staff are good. Well, at the time I mentioned, only 15% of our hospitals, one, was above the 50th percentile in patient experience. And the staff revolted, not the staff, the managers, because there was a financial incentive to it. You're setting us up to fail, Peter. This isn't fair. You're abusing the staff. There's no way you're going to improve with this. Like, you have to set it. What we normally do is just have them improve 1% a year. So one of our hospitals was at the 2nd percentile. Another one was at the 8th. And so I said, let me just pause for a second. You can look at it that I'm going to set them up to fail, but I believe our staff are better than the 3rd percentile, way better. And I am not going to tell them that that's what I believe you can perform in. So your job is to work together and set them up to achieve that goal, because our people are at least average. And it was like this transformational moment. We said, no, like, if we're not accepting 3rd percentile, and I mentioned this year, every one of our hospitals are now like above the 70th percentile. But it shows that mindset of the belief, right? People have been so constrained that we have to accept harm as inevitable. Another one of my stories that truly shows the power of this transformation, not just in healthcare, but in people's lives, was an environmental service worker. Part of our rules of belonging is that any project we do, any role that touches the process needs a seat at the table, because we genuinely believe they can contribute. And every site of care has to have a voice, because if they won't work if we don't fit it to their construct. So we had never included EVS workers on the team before, but we did. And when we first talked to this woman, she wouldn't look us in the eye, I think because we had led her in belief to be ashamed of her roles in EVS. It was truly profound. She wouldn't look. And she didn't believe that she had much to contribute. But we believed she did. And so we asked for her ideas. And importantly, we listened and we acted on them authentically. And she began to share some of her beautiful stories. Like, one of the things she shared is, and those of you who work in the hospital will get this, cleaning a room, especially after someone has an infection, is really a technical task. And we outsource it to a service provider. But they're training that. She said, I don't really understand how to clean it with that technical. We don't get great training. Our competency wasn't so great. And so we worked with them to make sure we do. And she also had ideas to improving patient experience. And what she shared was profound. She said, Peter, I've been doing this for like 30 years. And I noticed in virtually every patient, when you go in the room, there's some space that is their sacred space that they kind of make home. It's often the nightstand. And if you've been in a hospital, it would have pictures of loved ones. It might have a Bible. It has some artifact that means something to them. And she said, I've learned that you have to honor that sacred space. So I ask permission before I touch it. Some people don't want to touch it. It's theirs. But we said, wow, that is like so beautiful. So we started, training all of our workers on that simple but yet profound concept. Well, I mentioned we're data-driven, so every week we would put rates of infections in patient experience scores, and she took those graphs home and put it on her refrigerator, and she shared them with her family. She had 2 daughters who were struggling in high school and weren't really engaged, but they never asked her about her job, and she never talked, again, because she saw herself as I clean rooms. But she started sharing with them, look, I'm part of a safety team. I reduce patients' suffering, and they got energized and said, Mom, I want to go into healthcare just like you are so I can, relieve suffering. And she believed she reduces suffering, and she does, and her daughters just became so proud of her. Now, I want you just to pause and think about what I just shared for you. A management system that changed a family's future, right? Because someone helped someone believe another human could discover their purpose, right? Simply believing that people are worthy and capable. That is the power of believe. That is the power of belong. That is the power of building. And that is the power of this transformation model. Because loving doesn't lower our standards. Loving raises our standards because it raises people. And when people feel valued, they speak up. And when they speak up, problems surface. And when problems surface, improvement follows rapidly in this culture. So this isn't some magic formula. It is literally everyone in the organization feels worthy, they speak up, you solve problems, and I mentioned our biggest problems is not knowing how to solve these complex problems. And we have a whole 35,000 people engaged. And that is why this Living and Leading with Love is not simply a culture initiative, it is a framework for solving complex problems. It is a framework to truly create a learning organization and health system. And most importantly, it's a framework for unlocking human potential. As I think about this work that we do and your moment here, in every collective human endeavor, there comes a moment when the noise quiets, a moment when individual values become aligned around a common purpose, a moment when we know so much more about what to do than we may have admitted, and a moment when what once seemed impossible suddenly becomes achievable if you choose to act together. I believe Vermont is standing in that moment today, this morning. You have extraordinary physicians, extraordinary nurses, extraordinary caregivers, extraordinary public service, extraordinary communities. You have all the knowledge that you need. The plan that Craig showed is brilliant. It's transformative. You have the talent, you have the resources, you have the values, you have everything you need. But what remains, and it's crucial, is a decision. A decision about whether you will continue to operate in separate interests, each protecting your own corner of the system, or whether you will come together around something larger than yourselves. I think John F. Kennedy said it best when he said, united, there is little we cannot do in a host of cooperative adventures. Divided, there is little we can do. So the question before Vermont is not whether change is coming. It needs to. It is whether Vermont will lead. The question is not whether healthcare could be better. We already know it can. The question is whether we will have the courage to build it together. Living and Leading with Love is not a program. It's a choice. It's a choice to believe that every person is worthy and capable. A choice to belong to something larger than ourselves. A choice to build systems that transform good intentions into extraordinary outcomes. And if Vermont makes that choice, something remarkable can happen. You can become more than a state trying to solve its healthcare challenges. You can become a model for the nation. A place that proves healthcare could be high quality, affordable, accessible, compassionate, and sustainable. A place that proves collaboration is stronger than competition. A place that proves that love is not soft. It is the most powerful force for solving complex problems. Because the future isn't decided, it is created. And sitting in this room today, are the people who can create it. The choice is yours. You can continue to be shaped by the future, or together you can shape the future for the rest of the country. Small states have often changed the course of history because they could move where others were not able to. Vermont now has the huge potential to show America that healthcare could once again be organized around people, purpose, and love. Not because Vermont is the biggest state, not because you have the most resources, but because Vermont has something even more powerful. The ability to bring people together around a common purpose, just like you're all here today. Years from now, America's still going to be facing the question every community faces today. How do we create a healthcare system that is more affordable, more compassionate, more effective, and more human? Vermont can answer that question. Vermont can become the proof that caregivers, patients, universities, employers, communities, and government can work together, and when they do, extraordinary things become possible. And if that happens, people will not remember this as a meeting. They will remember it as a beginning, perhaps an inflection point. The moment the state stopped deciding to waiting for the future and started creating it today. The moment leaders chose courage over comfort, collaboration over division, and possibility over cynicism. The movement of Vermont showed the nation what is possible when people believe in one another, belong to one another, and build together. Because in the end, the greatest measure of leadership is not what we preserve, it is what we create. And if we create this together, Vermont will not simply improve healthcare. Vermont will provide the needed message to America of what we can be. And there is no greater legacy that you can leave than that. Thank you.
Wonderful. Thank you, Peter. Okay, who's ready? Sign up? So we know how we got here. Now we need to figure out how to get there with our healthcare system. So I have a question each for Pat and Claudia, based on their experiences and backgrounds, what they have seen and how they have helped to use this transformational process. What are those specific kinds of experiences they can share with us? And then we'll throw it open to all of you to ask questions. So let me start with you, Pat, if I may. So your background has been all around transformational leadership within healthcare systems. So one of the comments that Peter made was moving from hierarchy to partnerships, or maybe it was you, Craig, but sorry. So we have a lot of hierarchy in our healthcare systems. Can you just briefly describe how you helped participate in that shift?
Yeah, and thank you so much. It's always a tall act to go after Peter, who has got tremendous rhetorical skills. But what I'll start with is by contrasting where Peter and I came from. So Peter's a critical care doc. He has spent his time in the most sophisticated parts of hospitals. I am a psychiatrist that spent all of my time with the homeless for the first 10 years of my career, which is to say I spent time in shelters, which were among the least technically sophisticated parts of the health system you can imagine. Our two jobs could not, in many ways, have been more different. And yet, when we met for the first time about 8 years ago, we shared a tremendous amount in common, which was a common understanding that the systems that were built weren't working anywhere near what the evidence said they can and should be. Which is to say, whether it was someone with schizophrenia and heroin addiction, or someone who was on a ventilator in an ICU with heart failure, we noticed the same trend, which is that take the payment models out of it, take the incentives out of it, even despite those, it didn't look like health systems were doing all they could to actually make the lives of their patients and those they serve great and had been better. And that hit me during my residency, and so the last 20 years of my career, I've been very focused on what makes great leadership and why don't we have it. And the first thing I want to say is Peter talked about believe, belong, build. He talked about love not being the soft stuff, right? And the reality is that's backed up by evidence. And it's evidence that has been generated in research project after research project from folks like Amy Edmondson in psychological safety and Daniel Goleman in resident leadership, a whole host of others that say all of the things that we include in this model, they're all based on evidence. And that evidence can be summarized as we see it, and get into this hierarchical part, as the difference between taking a commanding approach to leadership, in which I see myself as the main expert and the decider. I am the one that has to have all the answers. I'm the one that has to make all the decisions. And if I give people my expertise and I make those decisions, then the folks that I lead will give me accountability and will show me love, right? And that's a model of leadership that many of you probably imagine can and has existed. By the way, that model of leadership is in no way backed up by the evidence. There's actually not a single study that shows that gets you great results. It's not that organizations can't get along, but they far trail the performance of organizations that are led by the other type of leadership, which we call cultivator. And a cultivator's primary roles are to be enablers and facilitators. And in that regard, what they are saying is, I believe deeply, I have unconditional regard for those I lead. They are worthy, they are capable. And my job is to unleash that potential by enabling the environment, enabling those individuals to do well, and facilitating people to connect. And connection is really, really key. And in return for that, what the organization gets back is amazing opportunities and amazing performance. Meaning, I show them the love and accountability. They give us the opportunities and the ideas, because the great ideas and the great opportunities are generated by the group, by the well-led, enabled, and facilitated group. And all the evidence points to that. And that essentially is what we have done. And the work, along with helping and build these transformational models and think about how we get data systems up and running, and think about how getting people to think about data in a very different way, and to think about their jobs in a different way, we also have built a leadership academy, the entire focus of which is to focus on the evidence that backs up what was just said there. It isn't soft. And the response of the about 100 people in our organization that we've run through that has been phenomenal. So we've had people run through training programs for years. We have some of those internally. We send people through MBAs. I myself got an MBA, and they're nice, and they're enjoyable. But
Inexpensive.
yeah, the stricter price on mine was $100K for an MBA. All of which is to say, but it doesn't appear to move the needle. What has moved the needle for the 100 or so people that have gone through the training internally that we've done in 40 hours, that is free to them, is that they all are now involved with transformational projects. Every single one of those people, and we keep track of them, and we don't just teach them, we actually follow them through afterward to help them, guide them on projects designed to make the system work better. Every single one of them is in. Every single one of them is excited. Every single one of them is affecting the folks that they work with. And building that capability doesn't require you to have the oratory capabilities that Peter has. That's awesome. And listening to him is like listening to great poetry for me. And I've listened to him talk hundreds of times now. It doesn't require that. It just requires someone committed to enabling and facilitating those they lead and elevating them. And by the way, holding them to account together, shared accountability. I'm responsible for making you putting you in a space where you're able to do great work and you have the capabilities to do the great work. And I will do the work of elevating your capabilities anywhere I can first, before thinking about throwing down a hammer and making you afraid and telling you you're doing a bad job. And if I do that, almost everyone succeeds. But in return, when I do that, I expect you to come follow me and do the excellent work that we know we can do. And here's the story. None of that is something people are afraid of. Not a single person we interact with, or almost no one we interact with, is afraid of that. They all run toward it, and the results have been amazing. So that's what I say.
Thank you for that.
That's great. Claudia? So with your background, and understanding the complex design of healthcare systems. There's a part of your world that has helped to reform processes and systems across business units. Can you talk a little bit about what you have worked on, how that has changed through the process you've been involved with, and give us an example of that?
Yeah, absolutely. Thank you, Lisa. Good morning, everyone. And then I'll say what Pat said. Following Peter and then following Pat is a big task. I'm delighted to be here today. As Lisa shared, I've been working with Peter for about 5 or 6 years and Pat almost as long. And I've been in healthcare for 35 years, my whole career, and I've worked in every part of healthcare. I started in long-term care. I have been a chief strategy officer of a health system. I've been a chief operating officer, and then a VP of strategy of a very, which is now Advocate Health. I did that. I also worked in consulting for about 15 years at Big Fours like Arthur Andersen, Deloitte, PwC, and I've never seen anything like what Peter has codified and implemented at university hospitals. I met him during COVID. He had been at Johns Hopkins, as you know, and did a little stint at United Healthcare, and said, I really miss provider, and came back and chose to go to University Hospitals Health System. He had many opportunities because he saw a place that was willing to change, a place that wanted to change, and a place that his heart is in population health. He wants to keep people healthy at home rather than healing in the hospital. So when I first met him, I was nervous because I was a partner at Pricewaterhouse and I was over our global digital health and on the provider side. And I was told by my boss, there's this hotshot, Peter Pronovost at University Hospitals, and he's a big deal, and you've been a COO, and so we'd like you to work with him because he's going to have to cut his quality department in half. And he's been given this task, and here he is, this global patient safety, and he's going to cut his department. His boss gave him a target to get to the 25th percentile in staffing. And so my team, who one of them we were just texting with yesterday, I had a team, and we put our heads together and we said, how are we going to improve quality with Peter, support him? And we did the work together. And I would say from the first meeting, I was nervous because he was such a big name. He was so humble, curious, and compassionate. He wanted to hear from us about what to do and our suggestions, and really led with love from the get-go. And I think that's how it's different. So a few things we've done to answer that question. One is we did get through that, and he still improved quality. He had a decentralized and a centralized operating model that he inherited. It was not his brainchild, and we created a hybrid model. But we pushed a lot out to the facilities, which should be, because being a COO, the one thing that operators don't like is going to a meeting unnecessarily. He talked about taking waste out. He doesn't love policies unless they're necessary. They reduced 1,000 policies in the organization by talking to nurses.
2,800.
Oh, sorry, more now, but my bad. 2,800 policies through, that's increased in the past 2 years. Through talking with the nurses, the environmental services, they know, the people doing the work know. And so reduced our CAs by a significant amount that really were unnecessary. 80%. And then we all, so that was early work, right? But then we also developed a program that they call Connected Care now, but it's intelligent clinical environment. So we brought AI to patient rooms and to look for things like pressure. If a patient's not moving, the AI can cue, well, this patient might get a pressure wound. Or you could possibly fall, this patient's on meds and the AI's watching, they look unstable. Let's get a virtual nurse to watch them. Virtual nurses watch 25 or so patients. Anyway, we implemented that as a pilot, and then it grew to all their hospitals. But it was different than what other people were doing, because we had physical therapists saying, hey, look at me. I can actually look at a patient now, and I can say, Lisa, I'm gonna walk 20 minutes to come see you. And please be ready, will you be ready? Because how much, 30% of PT's time was wasted walking, 50% of PT time was wasted walking the patient, and they weren't ready. That impacts sleep of stay, that impacts patient satisfaction, and all kinds of things. There are many other things we did, but that's a couple examples. But it was different, and I'll tell you why. It wasn't a top-down initiative. It wasn't, I've worked in for-profit healthcare and not-for-profit healthcare, and both have pros and cons, and I would say it's not a hammer. It's not if you don't do this, you're gonna lose your job. It's inspiring, and you bring out the love of people, and they want to do it. You can't hold someone accountable. You can inspire someone to hold themselves accountable, and that is probably, I would say, the biggest difference in the model. And I would like to add one more thing that I think is very different. Peter has started something. He had clinical transformation calls in the beginning. Everybody has clinical transformation calls. As a CSO and COO, I was on clinical transformation calls at my health systems. Over the time we've been working together, he read a book by David Brooks, and it's called How to Know a Person. And it talks about illuminators and diminishers. And he decided, I like to call this clinical transformation call, that by the way, in most health systems can be very cold and compliant. He uses the word compliant. And so he said, let's call it the illuminators call. And it's every Monday at 8 a.m. And you would not believe how excited people are. It's not a chore to present on it, people beg to present on it. And they talk about things. It started with music. Anybody on the team can choose a song, and there's a long list of songs. It needs to be about believing. John Mayer has a song, Belief, that will be played on it. Or Peter tell them a few of your favorite songs.
Respect by Aretha Franklin. The team members do it. One by U2, Fireworks by Katy Perry, but they all link to our values and our purposes, and they're just energizing.
So it starts with I was dialing early. I dial at 7:55 because I love to I'm a music motivated person. And then there's a patient story. And the stories will bring tears to your eyes on a Monday morning at 8. Just what happened over the weekend, or someone was dying and what they did for the family to make it easier on them. Whatever has happened, there's always a patient story, sometimes many. And then we get into the length of stay team at Ahuja will present, or what they're doing in connected care and how they're evolving it to the next hospital, or data and analytics, or the new AI tool that someone built to help with pharmacy calls to get meds to patients so they can go home with their meds when they're discharged. It just goes on. And then we close with music. Is there anything you want to talk about the eliminators call that I didn't? Okay, so those are things that are different because it's love. It's not compliance.
Thank you, Claudia. Did you want to ask one question before we go here?
I'd love to, if I could. So we have a lot of people here who work on programs outside the hospital. Advanced primary care, the Blueprint team. We have people here who work on mental health support services, community services. You have a large system. Curious if you could expand a little on how you bridge that, and what are some of the specific examples where you particularly help people get care in better settings outside the hospital? Because that's a big focus in Vermont, is to shift care to more appropriate settings.
Great question, and I could have spent a whole talk on this, or maybe I'll have to come back. We all are driving value, but for a frontline clinician, that word doesn't really mean much. Some people think cheap care or not high quality. So what our drive to our clinicians, or everyone, is really simple. It is to keep people healthy at home rather than healing in hospital. And if you're moving in that direction, you're doing good. And so I'll give you a couple things. We put in advanced primary care for 500 primary care physicians. So they have access to collaborative care with the social work, they have pharmacy access, they have access to an MA, now adding health coaches. Amongst our 120,000 Medicare beneficiaries, we went from 14% having an annual wellness visit, which is probably the most important thing for a Medicare patient, and that's about the national average, to 77%. But like all these things, excellence wasn't an option, and it was a clear outcomes to get first over 60, then over 75. We have 92% of our patients with diabetes are controlled. We have 90% of our hypertensive patients are controlled. And then importantly, we navigate care to the lowest cost of care. Some of that is regionalization where we do procedures and getting them out of our high-cost academic hospital where we could. So we move people and keep them for mostly quaternary care. You know, we were, like most AMCs, 80% of the people who get care in that setting don't need that care. AMCs do amazing things. They just happen to be filled. Some of it is we serve a very poor inner city, so people don't travel, so it's never going to be low because don't have access, and if they do have to, they don't have cars. But we navigate procedures as much to the lowest care setting possible. But I want to share with you what our results were in a population health perspective, because I think it's something you could do. Right now, the traditional Medicare patients cost $16,000 a year, the per member per year spent. Patients in an ACO cost $14,000 per member per year. Medicare Advantage, the data isn't published the same way, but MedPAC studies and other show that they're probably about at 20% even more expensive than traditional Medicare, but they report it in funky ways that like make it just. University hospitals is our per member per year spent is $11,000. Like, let me just pause in that. Like $3,000 versus all of the other ACOs, and $5,000 than traditional Medicare. Like you can do the math. If the country were to do that, I mean, we wouldn't need to make the cuts that we're doing in Medicaid. The waste would just solve it. And that, it's our ED utilization is about 30% lower because we have a really beautiful program for managing chronic diseases where we've partnered, again, the collaboration specialist with primary care to write care models and order sets that when they see the primary care, they know how to manage them, because many, especially the drug therapies, we have automatic referrals for any one of 6 chronic disease to pharmacists because we build trust with our primary care, and they get people on the right medicines, they educate them, they help them pay for their meds. We screen for depression and anxiety and make sure we refer people to our behavioral health. We have access to the specialist if we need to, but that model flipped it where 90% of chronic disease used to be done by the specialist, but because it's a silly model, we don't have enough of them. It seemed we measured how good you were by how long the wait time. So if it took you 3 months to get in, you must be good. If it takes 6 months, which it often did, boy, you must be really damn good, because the wait line, we flipped it to say 90% now is delivered by primary care, and 10% is by the specialist, but they're seeing people who they really need to see. And we have an NP first model for most of our problems, so even amongst, say, an endocrinologist, a diabetic NP or a social work and behavioral health will see most of our diseases first. Sometimes they're the only ones, because in our ACO, for example, we have 64,000 people with diabetes, and we have maybe 3 or 4 endocrinologists who see diabetes. The math doesn't work, but we viewed success as, is my clinic full, right? And that's like the docs, they were pressured for RVUs, and we have to get productivity. But we also needed to design a care model that can care for 64,000 people with diabetes, and that's not happening with a specialist-led model. So a number of different ways, and we're still innovating all the time. But I think it's a goal of really driving down Medicare costs in the state of Vermont would be just breathtaking to see here.
Wonderful. Thank you, Peter. Okay, now, everybody. First rule is, please introduce yourself and where you're from. So who would like to ask a question of our panel? Mr. Schubart. And oh yes, and Jared is going to be running the mic. Thank you, Jared.
My name is Bill Schubart, and a little over 20 years ago, I was asked to become the chair of the board of what is currently UVM Medical Center, right after the president was sentenced to a 2-year federal prison term relying the regulators. And I had to oversee the combination of 3 hospitals and foundation into what is today University of Vermont Medical Center. And my question really goes to the issue of there was no UVM network at the time. We just wanted to create a hospital that worked. My question is, are networks an artifact of the failed notion that competition, revenue growth, and expansion ensures sustainability?
Oh, sorry, thank you. Brilliant question. I have a little piece in Becker's on this exact topic, which we can share, but let me share with you. The evidence has shown that hospital mergers have largely driven up cost, mostly from price, has done nothing for quality, and so people rightly question the value. My sense is it's not because hospital mergers are bad, is because you didn't integrate clinically and for value. So like what, in our health system, every project that we do is a system project. I mean, everything that I said, it is across every one of our hospitals. We have an integrated quality program, and someone asked about how do you do this? What we have is, at our corporate level, with input, we design the management and accountability systems. So like all of our direct reports, we get the measures, we make the toolkits, but the local operators are accountable to implement it. In other words, we say why and what the goal is and report that and have forums for learning, but the local leaders figure out how to do it in my environment. When you do that, that's how we get the cost savings. That's how we could navigate people to the highest value side of care. Because if we didn't have that, it's just like competition, and you can't get, the 30% reduction when you get people out of the AMC to a high value care. I was speaking with our UVM colleagues, and it may be something you all consider. 3 years ago, we changed from the Joint Commission to DNV, and it was by far one of the best decisions that we've made. The main reason, or 2 main reasons, were that the Joint Commission is every 3 years. And so we had, like all American hospitals, this dysfunction where when they showed up, you'd hurry, plan, and scramble, and then you'd get sloppy. And I said to our board, that's not worthy of the trust of our patients. Like, if you believe in safety, safety is a way of delivering care every moment, every day. Because people don't choose to get care every 3 years. They come in every single day. DNV is an annual survey, and so you always have to be ready. And it first was more work, and people complained and said, well, just be ready. Like, have this be a way of living. And it had. We then moved to get ISO 9001 certified. It's, where regulators in healthcare are the floor. They assure safety, but they will never ensure excellence, right? They're never going to give you the care that we want. ISO is a ceiling. It is in 150 other industries, very few in healthcare, and no health system. We're the first health system, not just in America, in the world, that got certified by every hospital, but also as a corporate entity. Because to get certified in ISO, and if it was required, you would solve your problems, because that certification requires that for everything in your organization, whether it's contracting, clinical quality, you have to say what you do what you say, prove it, and improve it the same way at every one of your hospitals. So it's not an easy task. It couldn't happen without living and leading with love, but with it, it's just an accelerant. And so I actually just did propose this to the House Ways and Means Committee of saying, and to CMS, incentivize hospitals to get ISO 9001. It would solve this stupid problem that they're financially integrated but haven't operationally integrated.
Thank you.
Great, thank you, Peter. Next question, Dimitri. Sorry, we'll get the back in the next call.
Thanks. Dimitri Garter. I'm on the board of Southwestern Vermont Medical Center, and I ran a data analytics company for 35 years, so I naturally go in the weeds immediately. 2 questions. I've heard you speak a couple of times, Dr. Pronovost, and it's always inspirational. All I hear is Deming, but you don't use the language, and I have to assume that that's intentional. I think with the exception of waste, I'm not hearing the language of lean, and I know that that's not a tradition in healthcare. Coming from IT, it clunks a little bit because that's all I expect to hear. So I'm curious if that's intentional and why. My other question is about payment reform. So running the risk of feeling as though there's a silver bullet, and I realize that there isn't. I see payment reform at the very least as a missed opportunity if we don't aggressively pursue that. Changing the incentive structure structurally across the system seems to be something we're going to have to do regardless. So I'd be curious to hear your thoughts.
Yes, so great questions. Yes, we use lean, and we have a lean team we call operations engineers that run all of our data analytics and project management support for teams. But we didn't hire new ones, we had them, but they focus on, projects to reduce suffering, to reduce complications, to reduce waste, to take cost out, to reduce inequities. And so we use them. They'll often use lean. We have used it less for two reasons. One is it's a tool for some projects, but not for others. So lean's really good if I know what I need to do and I'm just not doing it. Much of what we're doing is we got to figure it out. So we do more design thinking that may then evolve into lean, because these are new things. Or another tool called dynamic work design that we've been driving. But mostly clinicians don't like jargon and they don't really connect, like going to the Gemba. We use it all. And then I would say third, and obviously I'm a student of Deming, and Deming clearly had culture in mind, and though people think of it as lean or the Toyota production system, it was really a management and accountability system, right? I mean, the way you understand it. So learning and culture were key. I think the pure lean doesn't bring the culture pieces into it as much. Though again, Deming did. It's just healthcare has forgotten the accountability and culture piece because in my view, accountability is almost entirely absent in healthcare. I mean, because there's no. I'll give you one. I don't have a slide. Well, I have a slide if you don't need it. We were trying to get our notes signed for a variety of reasons. It's a safety risk if we can't submit bills, and we had 10,000 notes a month that were older than 7 days being signed. And we complained, we said you have to do this, but we had no accountability system. So we trained people, we made sure that very transparently, here's the goals, here's some tools you can help get that done. But if you get 7 days, you'll get noticed what percent of your notes are late. If you hit a threshold at 14 days, you lose access to our EMR, which means you can't do your work. We went from literally within the span of a week, 10,000 a month to 40 a month. Like simply because we created accountability. I mean, it's all over the place. Second is, without a doubt, we need to align the incentives and payment reform. I strongly believe in transparency. I think that both for hospitals, but also for payers. I mean, if the payers had transparency, we would eliminate that 30% of healthcare that is administrative waste. And I see our Blues presidents here. That might be something to try, because let me just tell you where that 25 or 30% goes. There's rules whether you're going to pay something or not. And there was just a large study in Annals of Internal Medicine and a U.S. Senate report that showed for across 3 major insurers, they only agree on which procedures need prior auth 13% of the time. So just think about that. You're paying for healthcare, that decision should be science-based and evidence-based, and what it shows is simply arbitrary and capricious, right? I mean, it's nuts. If the rules were transparent, right, we wouldn't spend an army of and now adding AI to try to get paid, because what we do is we don't know what the rules are, so we submit a whole bunch of data. The plans hire a whole bunch of people to defend against it. Now we're both adding AI. It was just a study of the Blues they doubled their denial rate when they put in an AI system. So we put in an AI system, and it's like the stupidest arms race, that all you have to do is make your rules pay fairly, and technology would just ping those, right? I mean, like if it would make an efficient market. Name the rule, we'll give you the data that you need, you give us, you tell us if it's paid, and it's like, if you probably need a network effect, you need many plans to do it, because otherwise it's not gonna get the scales in many health systems. But boy, wouldn't it be amazing if Vermont could do a pilot like that? I think we do need Medicare shared savings, and Elliot, and we've been talking, Pat and I have been talking about this. I think that's probably the most effective chassis that we've seen, far more than Medicare Advantage and controlling costs. We have working with CMS and House Ways and Means to create more incentives to get hospitals into Medicare shared savings, especially those in traditional Medicare that are so much higher than others. The incentives, I think, are still weak. I mean, we still make too much money on complications personally. Like that should be ratcheted up so that hospitals really focus on them. And the flip side, we should be rewarded more if we drive cost out. The reason I didn't focus on it is that improvement in our Medicare shared savings, 11,000, that happened with us being at the level B in Medicare shared savings. In other words, one side risk, 40% savings. So hospitals could get cost takeout without necessarily a change in that. I think being in MSSP helped, because we went from about 2 million shared savings to 55, and that was like 30% of our EBITDA. So the Medicare shared savings helps a great deal. So I see these as synergistic.
And Dimitri, I really love your question, because one of the first things when Peter and I were working together, I worked at a health system, and we had a lot of people from Toyota and everywhere, and we went and we did the Gimbal walks, and I ran the transformation management office and as a VP of strategy. And one of the things I said to Peter is, this is lean. And he said, it has lean components, but he felt like lean was, even though you have Gimbal walks and things like that, top down and also some fear. And I will tell you, in our organization, we use the A3 methodology. We have mother A3s and strategy, everything. Current status A3s. One of the things I learned was we wanted to create a cultural transformation in the Charlotte metro area, and we picked one of the best performing hospitals, and we wanted to show everybody that red was okay. We were trying to get, that red wasn't we were bad, red was you didn't have the right resources or you had a political problem that we as leaders were not solving for you. But his way came out better, because that actually had some challenges with people, because it was so hard to culturally get people ready for red. So it was very top down, and I think this has a lot of that, but it's even better because it's bottom up and it's love versus a hammer. And I actually want to add something if he's ready in the future. It's not just a hammer, it's a handshake, and it's also a hug.
I like it.
All right, hammers and handshakes. All right, back
I
in the.
think Pat has something really quick.
Oh,
We got
sorry.
limited time. We'll
Okay.
find
Can you hear?
Now we can.
Better.
One of the things that draws us to this meeting was that you've already reduced the cost by 30%. So my question to you is that if you were to create a pie chart of costs before you started and where you are now, and you looked at like personnel, it's probably 70%, I'm guessing, and then the shares for facility costs and drugs costs and IT and high-tech equipment and that sort of costs. If that was your 100%, then and you shrunk it 30%, how's the pie chart changed? Has the number of people changed, or the cost for personnel, or cost of equipment, or what?
Yeah, so great question. As the hospital operators in this room know, it's a really dynamic, because like our costs are going up 10 to 12% a year, our payments or revenue are going up 3% a year. So like every year we have to get better. We have a cost and Eric, we call it an expense and revenue cabinet. Our CFO chairs that. And We initially did some across-the-board cuts that were mostly open rec, so it didn't take dollars out of the run rate, and it wasn't super effective. We then had every org unit do a functional org chart, like so literally say, what work do you do, and forget names, just and what are the key outcomes, the outcomes and key results that you drive. That was really helping us get rid of headcount. We also had, we grew our management levels much more than our FTEs. So we had a lot of directors or even some VPs who had one or two reports that got rid of that role, consolidated into others. We got input from all of our staff, as you would imagine. So the expense cabinet had a number of things. One, a big focus on labor, and particularly premium labor. During COVID, we went from spending about $2 million a year on premium labor to $200 million a year, right? Because there was all these PE firms that were charging crazy rates. I mean, it was like insane to get people with no more, so that's been very actively managed down to get that, and it's that's down. It's probably around 70 million now, so like still coming down. We have much better control of headcount now. Like a lot of health systems just grew headcount and had very little discipline controls. We essentially every position is rigorously scrutinized, and because it just grows. Like when you're a big organization, as people, all kinds of ways you can get around it. We looked at all of our purchase services. So we looked at we cut our IT expenses. We took about 400 million out of our parent, which is like all the corporate offices. Like you heard, the quality department got cut by half. Legal, every department had to cut. So our cost per discharge, is down probably 20%. The challenge is it's not static, because with inflation, every year we have, probably another 200 million that we have to take out just to make up for drug costs, for supply costs, that, independent of improving performance, just to stay the same because of the headwinds we face. And now, we're starting in 27 with the one big beautiful bill and the Medicaid cuts. It's additional several $100 million a year that we have to also, make up for. And so hospitals across America and Vermont have huge headwinds, and it's why I believe like the biggest problem is solving problems, because we have scores of problems that we have to solve to keep ahead of this.
I think one thing really important to add to is when the cuts happened, we did everything to repurpose people in other positions. He had people in the volume department that were great clinicians. They went back to clinical care. They still had a job. And some people were retrained. They became community health workers. They did different things, but because there were needs in other parts, and to help the pop health, so even though there was an investment being made over there, it had a return on investment, and it wasn't just an administrative overhead position. Because I think that's really important. That's part of living and leading with love too, is these are people's lives, and if we can repurpose someone, retrain them, or put them back in clinical care, that's the most important thing.
So my watch says we're almost at 10. So I know there's other questions on the floor. However, our panel is going to have to get someplace else too. So on behalf of all of us here, I just want to thank you all for being here today, being present with this group, being straightforward and direct about what the lessons were that you have learned along the way, being inspiring to the rest of us who now are going to be in this transformation process together. And we would love to be able to call on you again to show off all of the progress that we have made going forward. So let's all give our panelists a round of applause. There are still have refreshments over on the side. I hope you can stay and take advantage of some of that. And we're done for this morning. Thank you all.